Hi everyone, welcome to our first Pass the PSA session of 2025. My name is Anna. I'm an FY2 doctor at Manchester Royal Infirmary. And I've got Sophia with me as well.
Hiya. I'm an F1 in Northern Carolina, just at the top of Manchester. I apologise in advance if my microphone's a little bit wobbly.
Touch wood, everything's going to go swimmingly, but just let us know in the chat if there are any problems during the presentation. Okay, so let's get started. I've just got some learning objectives to go through. So here we are. This is what we're going to cover in the first session. So I'm going to teach you how to navigate Medicines Complete. I know most people are familiar with the BNF because from day one of med school, that's what we're used to using. There are some advantages of using Medicines Complete, and sometimes med schools don't go over how to use it very efficiently. So hopefully I can direct you and give you some good tips. This session mostly focuses on prescribing, but we will go over some drug monitoring, and we've got a calculation question as well. So if we just go to the next slide. This is sort of the structure of the PSA. There are 8 sections. The majority of the marks which we'll go through are the prescribing section. And here we can see we've got the prescribing section there, therapeutic, drug monitoring, section 7, and calculation skills, which we'll go over today as well. There is another session, isn't there, Sophia, that goes more in depth on calculation skills. This is just addressing clinical factors. The PSA has 200 marks, and you've got 120 minutes to go through the exam. So it is very time pressured. You are going to feel rushed, but that's entirely normal. It is sort of reflective of real life situations when you get to working. Some of you might be foundation doctors and some of you may be final year medical students, but it is a time pressure environment when you're on the wards. And so annoyingly, it's true to the NHS. There are a couple points here that I'd like to mention. Because it's such a time-pressured exam, you need really good time management and efficient use of the BNF. So that includes, if you don't know it, to just flag it and move on. There's no negative marking, so at the end, if you come back to a question you're still not sure, you should just fill something in if you really don't know the answer to the question. I've got some resources at the end as well that will help practice for the PSA. So I know that PSA teaching isn't the best covered in medical school, but the best thing you can do is really mock exam style questions. So I'll put you in the direction of some past papers and some question banks as well. It's a computer-based exam, so make sure you've activated all your accounts beforehand and have your password handy for the day. And also make sure you go through the BNF and Meds Complete and know how to use them before you attempt the exam. So next slide, please. So this is our recommended sort of overall timing that you spend on each section based on the number of marks. So you can see that prescribing is a whopping 80 marks out of 200. So that's why you should spend the most time on it. And the rest of the questions are 2 marks each usually. So things like providing information, that they really shouldn't take long. It should be 30 seconds per question, whereas calculation, we've allowed a bit more time because it can be a bit tricky with 2 or 3 step questions that you need to make sure that you know you're working out to before you answer them. Next slide, please. So yeah, this is the prescribing section. So this is from the PSA blueprint, so published by the British Pharmacological Society. Got a link at the end as well, of which are the common topics that come up for the prescribing section, which is obviously very useful to know, so you know which topics to revise. The sort of saying that the blueprint, it emphasizes sort of there is a base knowledge that a minimally competent foundation doctor should know. So yes, the BNF will help you, but there are some things that are not in the BNF that you will need to know, and that's why it's important to go through these topics as well beforehand. If we just go to the next slide, please. Oh, just before I do, could you just go back? So the ISOM style usually represents a clinical scenario, and then it asks you to prescribe a single appropriate medicine or an IV fluid. And so it's usually 10 marks, so 5 for the correct drug and 5 for dose, route, frequency. And for IV fluids, it's slightly different. I think it's rate, volume, and something else that's not. Rate, volume, and duration as well. So how it's marked, I'll just go on to that next. You get 5 for the medicine, and the most optimal medication will score 5 points, and then the British Pharmacological Society, the PSA organization, will preemptively come up with other drugs, because inevitably there is some variation on what you can prescribe and what's appropriate to prescribe, and we'll rank them from sort of 4 to 0. And then you can also get marks for the dose, route, and frequency. I think one thing to note is if you prescribed an inappropriate drug or a suboptimal drug, for example, that's worth 2 marks, you can only then score 2 marks in the dose, route, frequency section as well. So yeah, next slide, please. Then we've got the drug monitoring section. So that's 8 questions, which is 2 marks, which are 2 marks each. Common topics include, digoxin, insulin, methotrexate, amiodarone, carbimazole, and levothyroxine, statins, things like that. Got a handy list there. So again, this is typically not on the BNF. There are some medications that have monitoring on the drug monograph page, but some of these don't have it on the drug monograph page, so it's useful to go over these topics and find out the monitoring requirements for each drug. We obviously can't do that for every drug that could be included in the PSA until like 10 p.m. So there will be. This is just to guide you in the right direction. Next slide, please. And then calculation skills, like I said, we've only got one list, so it's spent too much time on it, but sort of, again, an overview of what could be included in that section too. So you do have access to the BNF during the exam. So like I mentioned before, you've got access to either the BNF and the BNFC, or you've got access to the BNF through Medicines Complete as well. And because the medicines, everyone's sort of familiar with the BNF, so I'll just go through Medicines Complete. That's next. This is sort of an example of why I think it's useful to be familiar with Medicines Complete as well as the BNF. For example, I don't know if you've ever been in OSCE and you've got to prescribe for a community-acquired pneumonia, and you're sat there with the iPad and you're panicking, typing in pneumonia, nothing's coming up on the BNF. Whereas if you go on to Medicines Complete, if you type in pneumonia, the search function is just miles better, more advanced, so it will come up with the right treatment summary, which is respiratory system infections, antibacterial therapy. Whereas on the BNF, that's just something you need to know, that's where pneumonia is. It's just a more comprehensive search engine than the BNF. So next slide, please. Yeah, so this is the home page of Medicines Complete. You would then scroll down, there's a little arrow at the bottom, and that would bring you to the next page, which would show you the BNF and the BNFC, which you will have access to during the exam. And then if you click the BNF, for example, it would bring you to this. There's some real key areas here to look out for. So you've got drugs, which will obviously have all your drug monographs on there, the treatment summaries, such as respiratory system infections, and guidance. And we'll just go through what each of those pages include. So the first one we've got is treatment summaries, and you can organize that by either condition or by body system. and it's arranged alphabetically. And then you've got your drug monographs as well, which is also arranged alphabetically. Although most of the time it's just quicker to search the drug instead of going through the drug monograph page. And then also guidance. So this is where all of our lovely, prescribing palliative care pages lies, prescribing hepatic and renal impairment. So these are also really important. And it's just nice that it's all grouped together on Meds Complete. Right. So I think that we should attempt the questions now. Let me just check chat to see if there's any questions. No? Okay, shall we get started on the questions then? So I'm going to give roughly attempting seconds per mark, but we'll read out the question to you, so we might just spend a little less time for the prescribing question, so you have enough time to look through the BNF and actually come up with a prescription. So let me just get a timer.
We're going to go through all of the questions, 10 questions, one after another. And then after we've done the questions, we're going to go through the answers all together. So if you haven't already, just have BNF open. If you're familiar with Medicines Complete, you can have that open as well. And have a piece of paper and a pen ready if you need to jot anything down. You'll get a piece of paper and a pen during the PSA as well. So give 10 more seconds for everyone to get BNF open. And then we'll make a start. So the first question. So this is a 42-year-old woman who has severe upper quadrant pain and vomiting for the past 2 days with a history of gallstones. And you can see that they've got asthma and eczema. On examination, drowsy, pale, high heart rate, and a low blood pressure. Though she does have warm peripheries and normal heart sounds. You can see the bloods. ECG shows sinus tachycardia, chest x-ray is normal. So your task is to write a prescription for one IV fluid that is most appropriate. And you'll have approximately 2.5 minutes. This one should be relatively easy, so we'll move to the second question. So this is a 69-year-old man on the stroke ward having experienced right and dysphagia starting around 24 hours ago. He's currently nil by mouth. And on examination, normal temperature, heart rate is fine, blood pressure is slightly on the high side in keeping with his hypertension. JVP is not visible. Heart sounds are normal, no peripheral edema. He's catheterized and he's got a urine output of 80 mils per hour. His estimated weight is 80 kilograms. You can see his blood results that are largely within range, and his CT shows are in keeping with his stroke. So far, he's received 2 bags of sodium chloride with potassium, both 1 liter, both over 12 hours. So your task is to write a prescription for one IV fluid that is most appropriate.
That's 1 minute. That's 2 minutes. And that's 2 minutes 30.
Thank you. So don't worry if you struggled on that question. IV fluid prescribing is always a tricky one. Third question. A 30-year-old woman is in the emergency department with irritability and drowsiness. She's dropped her GCS from 15 to 9. She's got a past medical history of type 1 diabetes and normally takes Novorapid and Lantus. On examination, she is unresponsive and clammy. Temperature's fine, heart rate is on the high side, but it's regular. Blood pressure is okay, and saturating fine as well. A VBG is done, make note of those results. And the prescribing request is write a prescription for 1 IV fluid that is most appropriate to treat her symptoms. So to answer this question, this requires a certain level of background knowledge that Anna was talking about before.
That's 2 minutes. And that's 2 minutes 30.
Thank you. Next question. So 23-year-old woman presents to the ED with 1 day history of abdo pain, nausea, and vomiting. Doesn't have any past medical history, and on examination, she's drowsy, and she has a normal temperature, heart rate is elevated, blood pressure is low. Her respiratory rate and oxygen saturations, her respiratory rate is a bit high, but her oxygen saturations are doing okay. She's 60 kilograms. And make note of the CAP glucose results. And she's had an ABG as well. So the prescribing request is to write a prescription for the initial insulin therapy required to treat her DKA. So this one is pushing the limits of what you would be asked in the actual PSA, but still something that you could be asked.
That's 2 minutes. That's 2 minutes 30.
Thank you. So that's the end of your question. And we'll continue on.
So we've got a 34-year-old man presented to the emergency department with 2-day history of worsening shortness of breath, chest tightness and wheezing. He's been using his reliever inhaler more frequently, but it's not working, feeling increasingly fatigued, and his symptoms are worse at night. He's got a history of asthma and hay fever. He's on a Clenol inhaler, 2 puffs daily, salbutamol inhaler is required. The social history is listed there. On examination, his obs are listed. You can note he's tachycardic and his respirate is elevated and his sats are down. Despite being on 15 litres of oxygen via non-rebreathe mask. He's not able to complete sentences on examination, and he's got a bilateral diffuse expiratory wheeze. The question's asking you to write a prescription for one medication that's most appropriate to treat his symptoms, and I'll just give you a minute to answer this. Not a minute, sorry, 2 minutes and 30 seconds.
1 minute so far. Two minutes so far. Two and a half minutes.
Great, and moving on to the next question. We have a 65-year-old woman presenting to A&E with a 2-day history of worsening shortness of breath and a cough, which is productive, past medical history of COPD, type 2 diabetes, and osteoarthritis. On metformin, 500 milligrams twice daily. Salbutamol inhaler is required, and a Foster inhaler twice daily. Temperature is borderline. Heart rate is 92 minutes. Bit raised. Blood pressure 140/85. Respirate is raised. Oxygen sats are 88% on air. You can notice she's using accessory muscles of breathing and can hear bilateral wheezing, scattered crackles, and auscultation. She's commenced on oxygen, salbutamol, and ipratropium nebs. Write a prescription of one additional drug that is most appropriate. I'll give you another 2.5 minutes for this one. After this, we'll be moving on to the shorter questions.
Two minutes so far. That's 2.5 minutes.
Thank you. Moving on to therapeutic drug monitoring, so you have a minute per question. 58-year-old woman is commenced on atorvastatin for the secondary prevention of cardiovascular disease following a recent MI, PMH of hypertension and ischemic heart disease, on bisoprolol 5 milligrams once daily, aspirin 75 milligrams once daily, and ramipril 10 milligrams once daily. Which of the following is the most appropriate investigation to monitor for adverse effects of atorvastatin after 3 months of treatment?
And that's 1 minute.
Thank you. Next question, 50-year-old woman is commenced on levothyroxine for primary hypothyroidism. At what time intervals should thyroid-stimulating hormone be checked during the first year of levothyroxine therapy?
That's 1 minute.
Thank you. 29-year-old woman is being reviewed in the outpatient psych clinic following a recent discharge a week ago from the ward due to schizoaffective disorder with depression. The clinic is to review her clozapine medication due to previous treatment resistance to olanzapine and risperidone. Select the most appropriate parameter to monitor at this point in time whilst the patient undergoes this new treatment.
That's 1 minute. Last question.
Well done, everyone. Getting there. 8-year-old child with a history of epilepsy presents to the emergency department and status epilepticus. A loading dose of phenytoin is administered. You are asked to prescribe a maintenance dose of phenytoin sodium. The child weighs 24 kilograms. It's available as a 250 milligram per 5 ml ampule. Which volume of phenytoin should be administered per dose to 2 decimal places?
And that's time up. So very well done, everyone, for getting through those 10 questions. I hope you didn't find it too stressful, but also a little bit stressful so that we know you're learning something. So we'll go through the answers. So starting with the fluids questions. So prescribing in general is the most intimidating part of the PSA, and fluids in particular always make everyone very confused. So the easiest way to think about it is 4 different categories: resus, maintenance, whether you're replacing anything, and any additional fluids that you might need to give. So for this first question, she's hemodynamically unstable. You can tell from the high heart rate and the low blood pressure. So fluids to give is a resus fluid, a crystalloid fluid. And that is typically 0.9% sodium chloride or plasma light, 500 mils given over 15 minutes or less. Sometimes you say stat, but the PSA doesn't actually let you type stat into it. So it has to be 15 minutes or less. So if you got that correctly, then you can give yourself 10 marks. These are other acceptable answers. So this is what we were talking about before. So you have to get the drug itself correctly. And here they only accept crystalloids or ringers or Hartman's. We'll talk about those a bit later. And if you got on that, then you can award yourself 5 if you got it correctly for the rest of the answer. But if you didn't get any of these fluids, then you get 0 marks. So that's why it's really important to know the drug that you want to prescribe. So as we know, we have to give resus fluids. This page isn't actually on the BNF. This is taken from the NICE guidelines. It's some of that background knowledge that you just have to know. You give a bolus, 500 mils, over less than 15 minutes. Very unlikely they will give you a sort of question where the patient has heart failure and the answer is 250 mils. It's more likely going to be 500 mils. So just try to memorize that. It'll be useful for OSCEs as well. This is what it would look like on the actual PSA platform, the software. I recommend, if you don't already have an account, you should do an account on the PSA official website. And there are 3 practice papers on there that you can have a go at. They will get you into the rhythm of the format of questions, but we all found that the questions on the practice assessments are a lot easier than what actually shows up in the actual exam.
Did you want me to go through the website, the prescribing safety assessment website, quickly?
We could do it at the end.
At the end, yeah, no worries.
Thanks, Anna. So this is a brief table of all the different types of fluids you can prescribe. It's taken off the NICE website. It looks very intimidating, but the key things that you need to know here are the sodium chloride 0.9%, the glucose 5%, and the Hartman's. And sometimes you'd also give sodium chloride 0.18% with the 4% glucose as well as a maintenance fluid. But there are other types of fluids out there, as you'll see on the PSA website. It'll come with a longer list of different types of fluids. But those are the main ones you need to know about. I say that it's quite cheeky because the next question doesn't have any of the fluids mentioned in this table. But we'll get to that. So just try to remember the sodium content of each of these fluids and the potassium. So for the second question, so he's hemodynamically stable. So we know that he doesn't need resus fluids. He's nil by mouth. He's had a stroke. His urine output is okay. We know that anything over 0.5 mils per kg per hour is okay. So he's doing great. So he doesn't need any resus fluids. He needs maintenance fluids. So this is a bit of a tricky question. And if you got this right, then you're sorted. But this question is here to demonstrate how you would work through giving maintenance fluids. So the answer would be glucose 5%, potassium chloride, 0.3% solution, 1 liter over 12 hours. And these are the other acceptable answers. So we'll go through it step by step. So maintenance fluids, we have a daily requirement of water, sodium, potassium, and glucose. Those are the 4 main components of maintenance fluids. And so we know this patient is 80 kilograms, so they would need approximately 2 liters to 2.5 liters of water, 80 millimoles of sodium, 80 millimoles of potassium, and everyone, regardless of weight, needs about 50 to 100 grams of glucose. So what we can calculate so far is that they've had 2 bags of the 0.9% sodium with the 0.15% potassium chloride. You just kind of have to know that 0.15% potassium chloride equates to 20 millimoles. And that's 1 liter of that bag. 1 liter of potassium chloride, 0.3%, equates to 40 millimoles. And we'll talk about how we can think about percentages and conversions from liquids in a second. But that's just something that you'll have to remember, unfortunately. So we can calculate that this patient has had 2 liters of water. They've had 308 millimoles of sodium, 40 millimoles of potassium, and no glucose. So this patient is very much at risk of sodium overload and is in a potassium deficit and has received no glucose. So we need to top that up. So the best options here would be the glucose 5% and the potassium chloride 0.3% over 12 hours. This might make it a little bit easier to show you. So when you write glucose in the PSA, it will give you a list of solutions, and you can see the only 2 options here are glucose 5% with the potassium chloride 0.3% solution. That's the only one that matches exactly what we need. I appreciate that you might not have had access to this beforehand, but it's always useful to think about what is the patient in deficit of and what do they need. So as a summary, this is on the left side, that's what the patient got after their 2 bags of sodium chloride with the potassium. And then the middle one is what they'll get after their prescription. And the last one is what their ideal would be. So you can see they've gotten enough water. They still got too much sodium, but the potassium is getting there and the glucose is getting there. And their next bag could always compensate for that. So if you made a note that this patient needed glucose and this patient needed potassium, and give yourself a pat on the back. Next question. So this is a hypoglycemia question. So they've already got a background of type 1 diabetes, and their GCS is dropping. You can see that their glucose is 2.2. So they're having a hypoglycemic episode. And the best thing for this patient would be to give them glucose. They're hemodynamically stable, so you don't need resus fluids. So you can appreciate that it might be tricky to find the exact volumes on the BNF. We'll talk through that. So if you type in hypoglycemia on the BNF, it will give you roughly what solutions you need to give. So it says glucose 10% or glucose 20%. If you wrote 50%, then unfortunately that would not score you a mark because, as it says, it's not recommended as it's hypertonic. So this is another useful page. The medical emergencies in the community page actually shows us the exact volumes of glucose that we need to give. And you can see here, if you gave 10%, then you'd need to give this adult between 150 to 200 mils infused over 15 minutes, and also 20%.
And just to note that medical emergencies in the community page is also very good for peds prescribing. For example, in a patient whom you suspect has bacterial meningitis, which dose of benzyl penicillin to give.
Yeah, definitely. No, we'd highly recommend the medical emergencies and community page. Just have a look through those. And it's useful for OSCEs as well, because you could be asked any of the scenarios in your OSCEs. So this is another question on how to convert between percentages of glucose and bringing that into grams. A lot of people do get confused about what does this percentage mean. So if you just think about if 10% refers to 10 grams in 100 mils, and write that down on a piece of paper, even at the start of your PSA exam, just write it at the top of your blank piece of paper. It will help with your conversions and dose calculations later on. Fluid prescribing top tips. We did also have the insulin question. I think it's after this top tip section. But so the main top tips for fluid prescribing are, think about whether it's any of these 4 scenarios. So resus fluids, correcting the emergencies. So that's like your hyperkalemia, hypercalcemias, and your glucose, your hypoglycemias. Thinking about whether it's maintenance, and then replacing any fluid losses. And we've made a little handy table here for you just to go over it. This is the easiest way to think about fluids in the PSA and in clinical practice. Just take a screenshot. You'll have access to the slides later as well. And if you just try to memorize this little flow chart, then you'll be able to just prescribe fluids in any scenario. There we go, insulin question. So this question already tells you that she's had a DKA, and it requires you to have that clinical knowledge on how to treat a DKA. I think of it as VIP treatment for people in DKA. So you need to give them volume, insulin, and potassium. So assuming that you've already given the insulin, this question, the resus fluids, this question is asking about the insulin. And the most appropriate answer here would be the soluble insulins, such as ActRapid. Dose would be 6 units given intravenously. So we'll talk through this question. Insulin prescribing is quite a hard one. Other acceptable answers, any of the soluble insulins, got NovaRapid, Apidra, Humulin or Humalog, and gives 6 units IV. So we know for DKA, you need to give 0.1 units per kg. And it's a fixed rate of insulin. The BNF doesn't exactly have any clear guidelines. The NICE page does, but it redirects you to the JBDS guidelines. And so we've highlighted it here. So if you've memorized this, then great. You know you have to give ActRapid or Humulin S at 0.1 kilo per hour. But the PSA system does also help you a little bit. So if you know you have to give insulin, it gives you these options on what you can prescribe. I think of anything that has like RA in it, like NovaRapid or ActRapid, acts either rapidly or is a short-acting insulin. And the ones that begin with L, like Levemir and Lantus, are the long-acting ones.
Glargine as well, long-acting. And
Glargine. So if you search in the BNF, just type in insulin, it will give you a summary page of all the different types of insulin. And if you already know you have to give some type of soluble insulin, then it would point you towards insulin aspart, which is just the generic name for NovaRapid. And so that's why these ones are all accepted. Insulin glutathione as well is accepted, and that's Apidra and Lispro as well. Alternatively, so if you're familiar with the monograph of a drug on the BNF, if you scroll down, it will have medicinal forms, and you can click on that, and it will show you how the drug is actually available to administer to the patient. So if you click on that, it will show you this page on which ones are soluble to give to the patient. And again, it reiterates that you could give NovaRapid or Humulin S. So it just shows that there are multiple ways to reach the right answer, but it's just knowing where to find it. So click around on the BNF, familiarize yourself with using Control F as well to find specific things that you need, and get used to using the search bar, which would be very helpful for adverse drug reactions, things like typing the drug, using and typing each reaction in turn to see which reaction matches with which drug.
And medicinal forms is really useful for fluids as well. For example, if you've forgotten which fluids have potassium in them, you can look up potassium chloride and go onto medicinal forms and solutions for infusion, and it would come up with the available fluids that you can prescribe that have potassium in them.
Just a quick summary on the difference between DKA and HHS. The way we think about it is DKA is something that type 1 diabetics tend to get, and it tends to be a very acute thing that happens. The reason being is because it's acute because of that buildup of ketones, and so their blood sugar tends to go up a lot faster compared to patients in HHS. The patients with HHS tend to be type 2 diabetics who have had diabetes for a longer time, and they slowly build up their blood glucose, so the body can kind of compensate for all these little changes over time. So they tend to present less acutely, but when you do find they have HHS, they tend to be very, very dehydrated. They have a very, very high blood sugar. And that's one way you can differentiate between these two conditions. HHS is slower, older patients, type 2 diabetes. DKA tends to have more acute, more pain, more vomiting, tends to be in younger patients, type 1 diabetics. I'll pass on to Anna for the rest of the questions.
Thank you. This shouldn't take too long because they're shorter questions, and I'm not actually going to go through the actual treatment of asthma and COPD, just point you in the right direction on how to get to these answers. So if you go back a slide, this is the answer that's on the question, sorry, on the prescribing. I didn't go through it, sorry. Yeah, so you have to be able to recognize that this man is having a severe asthma attack. That's sort of evidenced by the fact his saturations are low despite maximal oxygen therapy. He's unable to complete sentences and has an expiratory wheeze despite already having his salbutamol inhaler. So you have to figure out that this patient will need nebulizers instead of an inhaler, and the right drug to give would be salbutamol in this instance. 5 milligrams, although you can't, I think 2.5 milligrams is also an accepted answer, and 15 minutes or 30 minutes would be acceptable as well. So you press next. Yeah, there we go, 2.5 to 5 milligrams repeated every 15 to 30 minutes, or when required, so you could put PRN as well. So this is, I guess what I want to point out by this question is, if you know what to prescribe, search the drug first because you're skipping steps. So salbutamol should, in theory, come to mind. If it doesn't, that's okay. We can go through how to get to the answer. if you just type in salbutamol, you'll be able to get to the answer more quickly. But if you don't know what to prescribe, you can go onto the treatment summaries and look up asthma acute. There's also a separate treatment summary for asthma chronic. And then you can skip to management adults, which is highlighted in purple there. Next slide. And then we were talking about using Control F. So you could use Control F then, next slide, to type in neb, acute, sorry, and it would jump quickly to the relevant section. And you can also type in neb and it would jump to the nebulizer section as well, just like that. And it's honestly, it's annoying, but these tips do actually really help with your time management in the PSA, and it's what's going to make the difference. You need the time to think about the answer. You shouldn't use the time to root through the BNF, which is why it's so important to be familiar with Meds Complete and the BNF before the exam. Next question, please. So we've got a woman, 65-year-old woman with an acute exacerbation of a COPD. The temp is borderline, so it could be infective or not, but in either case, you would be prescribing prednisolone, and that would be a 30 milligram dose for 5 days, and it'd be once a day as well. To be able to get to this, you would either realize, sorry, if you could go back a slide, sorry. So she's already on, for an additional treatment, so she's already on oxygen, salbutamol, ipratropium, nebs. There's not much else we can give her in the acutely other than the prednisolone. And if you press next slide, either prednisolone will come to mind, or you'll have to go to the treatment summary where there is a COPD page. And then on the left-hand side in Meds Complete, it will come up with this section where you'll be able to see management of exacerbations of COPD. So part of the question is being able to recognize there's an exacerbation of COPD and working from there to see what's most appropriate to prescribe. Next slide. So here we go, short-acting inhaled bronchodilator. So I already prescribed the salbutamol nebs and can also give ipratropium nebs alongside this. And in the absence of significant contraindications, so this example of contraindications would be like adrenal insufficiency. And you would click on then prednisolone, it will just take you to the drug monograph. Just hold on 1 second. Yeah, next slide, please. And then once you click on prednisolone, the first indication that comes up on the BNF will be acute exacerbations of COPD, and it gives you the exact dose. Perfect. And then we've got a 58-year-old woman who's commenced on atorvastatin. So we're moving on to therapeutic drug monitoring. Now, this could catch some people out, I think, because some things obviously come to mind when we're thinking statin therapy. We're thinking we probably do need a lipid profile and we need a liver function test likely, and creatine kinase, well, that sounds kind of right. You can get myalgia when you're commenced on statins, but it's about what is routinely monitored at 3 months of treatment, and that would be liver function tests. And you can actually get this through the BNF, but there are some drugs where you won't find the monitoring requirements. So if we went to atorvastatin on the BNF as the drug monograph, next slide, we could jump to monitoring requirements, and it would show you that before starting treatment with statins, so not at 3 months, but before, we need baseline lipid profiles and triglycerides, TSH and renal function. But at 3 months, it's LFTs that we need, and we need to repeat that at 12 months. And then in terms of when it should be continued and discontinued, because that's another question that can be asked on the PSA, if it's not more than 3 times the upper limit, then it can still be continued. And then I wanted to just talk about CK as well, because it's a common thing that comes up. It's 8 p.m. So thank you for everyone who joined us for the hour. We won't take much longer to finish the session, but there is the feedback link in the chat as well. So yes, creatine kinase. This is only needed if the patient has unexplained muscle symptoms, and the only reason to discontinue it is if it's 5 times the upper limit of normal. And if it's less than that, it's very unlikely that it's the cause of their muscle pain is due to statins, and other things should be explored, other diagnosis. Next slide, please. Yes, question 8. So I was a bit annoyed actually because I edited this answer slide, but I didn't edit the question slide, and I wanted to keep it vague by putting thyroid hormone treatment for hypothyroidism instead of, but in the actual question I put levothyroxine. So that was going to be another step for you to figure out what exactly, which drug is it, and then what do you monitor in that drug. But we've given it away already. It's levothyroxine. And so how often should you be checking TSH during the first year of hormone therapy? And this is every 3 months until stable. Again, you can find this in the BNF. So press next. If, for example, you forgot because our minds are funny things, it's a time-pressured environment, you forget what drug it is that you use in thyroid hormone replacement, you could just type in thyroid. And this is what I like about Meds Complete, is because this wouldn't ordinarily come up on the BNF itself, but it will come up on Meds Complete. If you type in thyroid, the treatment summary for hypothyroidism will come up. And then press next slide, please. Yeah, I was just showing you what will come up if you type in thyroid in the BNF. Like, this is just useless for when you're in an exam. Next slide. And then it will show you that it's levothyroxine that's used. And it says also to measure TSH levels every 3 months until stable levels have been achieved, and then yearly after. Question 9. So then we've got a 29-year-old woman who started on clozapine. And it's a bit of a tricky wording on this question, I think, because it asks you the most appropriate parameter to monitor at this time whilst they undergo this treatment. And I think the key thing about this question is most important parameter. And it's full blood count. And that's because clozapine most notably and also severely can cause agranulocytosis, and is the most important side effects to be aware of. There are other things that you do need to do. For example, you need to do blood lipids and weight at baseline at 3 months and yearly, and that's because of the metabolic side effects of all antipsychotic drugs, but including clozapine. But the most important would be the full blood count to monitor the risk of agranulocytosis. And this is just from the PSA blueprint, which I will link at the end as well, about therapeutic drug monitoring. And it just says at the bottom there, examples of prescriptions that might require appropriate monitoring are digoxin for atrial fibrillation, inhaled corticosteroids, oral contraception, levothyroxine. And they're just examples that can come up and likely are to come up in the PSA, and worth revising before you sit the exam. And then our final calculation question. We've got an 8-year-old child that's in status. They've clearly not responded to initial therapy, and so phenytoin is administered. And a loading dose has already been given, so you need to figure out what maintenance dose needs to be given per dose. So if we go to the BNF or Meds Complete, we can find status epilepticus, and you need to make sure you're on the BNFC, and you need to identify the child as 8 years old. So this is the correct section, 1 month to 11 years to be looking at. The loading dose is stated, and then you need 2.5 to 5 milligrams per kilogram twice daily. So that's per dose. So 5 milligrams times by 24 kilograms, which is stated in the question, is 120 milligrams. And so we've got this sort of dose over volume times concentration triangle, which is another thing that you can jot down before the exam starts, just so it's there and you don't have to figure out what it is before you've been bombarded with like 150 questions. And so if you do 120, and then the concentration needs to be in milligrams per mil. So 250 divided by 5 would give you 50 milligrams per mil, and 120 divided by 50 will give you 2.4 mils. And because it also states 2.5 milligrams, you can also accept an answer of 1.2 mils. We didn't go over contraceptives in this, but we do have another session later on that will go over contraception. But this goes to show you how important Meds Complete is as well, because if you type contraception on Meds Complete, it will come up with all the relevant treatment summaries, including the IUD. And then if you press next, you can also just search missed pill, which is important in I think is it communicating information, and it will come up with the relevant drugs as well. So I just think, yeah, it's worth learning how Meds Complete works as well. Next slide. And then this is for upcoming sessions. So you can look at this before you come to our next session on Thursday. Next Thursday is Appendix 1, and it's just common interactions and common side effects from certain drugs. Really worth looking at. And then I've just also included some useful resources too on the next page. So this is the PSA blueprint. It's the curriculum set out by the British Pharmacological Society about how the exam is structured, what the aims are of each question. And I think that if you put yourself in the mindset of the person who wrote the exam, you will be able to understand the exam much better and understand what they're looking for as well. The British Pharmacological Society themselves have got 9 free e-learning modules that goes through how the exam is structured as well. I think it's really worth doing that, again, just to get the idea of the structure of the exam. And it's also from the official people who've written the exam as well. And there are mock papers available to purchase, but I would recommend that you go to the Prescribing Safety Assessment website, which is where you'll be taking the exam, because there are 3 free mock tests that you can do, which I can show you as well. In terms of question banks, I know Geeky Medics has a question bank, and so does, could you just go back, sorry, and so does PassMed. And here's a little link to the Appendix 1 interactions and script modules as well. These are sort of free modules available to any medical student and foundation doctors as well. And there's just a few modules that you can do. Monitoring medicines would be useful for therapeutic drug monitoring, and toxic tablets as well. So I think we did hit all of our learning objectives today. Just to remind you, we went through navigating Meds Complete. We did some prescribing, including some fluids, insulin, went through asthma and COPD, and then went quickly through contraception, and we managed to hit some drug monitoring questions as well. Let me just share my screen so I can show you the Prescribing Safety Assessment website. I have got it up. I do. Just bear with me. So here we are. This is the website once you've logged on. And then if you just scroll, you can get onto assessments. And if you click on this little tab here, you can get to practice assessments. And on here will be mock tests that you can do. And you can attempt them as many times as you want and reset the results as well. And then I'll just show you the format of the exam as well. And it's just really useful because this is exactly how you will see it in the exam. So if you know what the interface is like, you won't be surprised by it when you get to the exam. That's the last thing you want to worry about. And this is how they're usually structured. You've got a case presentation, an examination, and some investigations. you can type in any medication, for example, probably you want furosemide in this case. You can type in which tablets you'd want and dose and the route as well. And then you just press next. You can also flag. This would be flagging the questions to mark them for review at the end. And then you can just see which questions are flagged as well, because they'll have the little orange mark on them. Okay. I don't know if you wanted to go through the upcoming session, Sophia.
Yep. So if you haven't filled out the feedback form already, we'd really, really appreciate it. It can help us learn for the future sessions. I'll just go over the next few sessions that we have coming up. So if you haven't already as well, we've got a link tree. Oops. And we've got all of the things on there, such as how to sign up to our next session, how to join our mailing list, and all of the future sessions coming up as well. So our next session is next Thursday at 7 p.m. on the 16th of Jan, and we'll go through some of the other sections of the PSA. And we'll be running through to the 25th. So the 25th is a Saturday. That's a bit of an odd one. And it's going to be at 11 a.m. So we look forward to seeing you at all of these. And just to make you aware as well, we have a Road to Finals series coming up in March. And we'll be going through each of the main categories of the MLA and going through 10 high yield questions in an MCQ format. And similar to today, we'll give you the questions and we'll give you the explanations as well and any top tips to help you pass. Does anyone else have any other questions? Oops. I'll just put the link tree back into the chat. But thank you very much for joining, everyone. We know we went over time a little bit, but your feedback really does matter to us, and we do make changes, we do take it on board. So do let us know what you thought of it. We really hope it was useful and gave you a brief overview of how to do the PSA and tackle those questions. So all the best and hope to see you next week.
Thanks so much, everyone.
Thank you.